Today I'm joined by Dr Marc Coughlan, a neurosurgeon at Coastal Neurosurgery specialising in spinal injuries. The spectrum of back and spinal issues is very varied, from simply having a sore back to slipped discs and more serious injuries like spinal tumours and trauma. Many people suffer from back pain, especially as you age, and it can be scary not knowing how bad an issue might be. And for some, investigating this is even scarier still. But what are some of the red flag symptoms to look out for? Is getting your back cracked a good idea? When do you need an MRI? And when is surgery necessary? Let's get into it. So Marc, welcome to the podcast. Thank you so much for giving up your time to come after a long day operating.
Pleasure. Thanks for having me.
I'd like to ask my first question, which is, why neurosurgery?
I recall when I was studying at med school in Cape Town in South Africa, I was absolutely always fascinated by neurology and the nervous system. And I found it pretty challenging neuroanatomy. And I was kind of drawn to that, just the challenging anatomy. And I just got more and more intrigued with the nervous system, but I knew I wanted to be a surgeon. I don't think I'm patient enough to consult all day, and I love sort of the technical aspect. So it was a perfect combination of a sort of beautiful science in terms of the anatomy, plus a really nice, clean, precise, and neat surgery. I never enjoyed general surgery or bowel surgery.
Right, okay, too mucky.
I just couldn't see myself doing that, and straight away I kind of knew what I didn't want to do.
Yeah, amazing. And is that where you did your training, Cape Town?
Yeah, so I spent 6 years doing basic med school in Cape Town, and then I spent a year working at a bush hospital in Africa on the East Coast. That was a great year. And then after that, I spent all my time specialising back at University of Cape Town.
Right, okay, amazing. I spent 6 weeks in Cape Town when I was a medical student at Conradie Hospital.
Oh, wow. Yeah.
And I loved it. And I loved Cape Town.
Yeah, a lot of history in Cape Town, because we climbed into a lift one day, and who climbed into the lift with us when we were medical students but Christian Barnard.
Oh, wow.
Did the first heart transplant in 1969, if you remember.
Yeah, amazing.
Yeah, so there was a lot of history to that medical school.
Yeah, and I noticed that you worked in KwaZulu-Natal as well.
That's right. That was my internship. That was a great year. That was like an introduction to surgery, because there was so much trauma, because it was a civil war between ANC and Inkatha, who were essentially the Zulus. A lot of people would go there to train to do surgery because we knew we would see so much trauma.
Yeah, I spent a few weeks at Bethesda Hospital in KwaZulu-Natal.
Oh, okay.
I wanted to be a paediatric surgeon, and I started off doing surgical training. And then I had my first 2 of my 4 children and realised that I would probably never see my children. So I opted for a little bit of a pivot. But anyway, so Marc, tell me a little bit about neurosurgeons. Sometimes when people think neurosurgeons, they just think brain surgery and brain tumours. But you guys do actually a lot of other surgeries as well. Can you tell me a little bit more about what being a neurosurgeon is? Yeah,
so neurosurgery, I guess, really, and especially our training, encompasses the whole nervous system. So a large component of it is brain surgery, and a large component of it would be spinal surgery. And a lot of it depends on whether you branch out into pediatric neurosurgery or adult. And these days it's becoming a little bit more subspecialized, like most things. And you tend to either sort of find yourself doing more spinal surgery or limiting yourself to more cranial or brain surgery. Or some people do both, but generally you would find a niche and you'd be angling towards that. And that's the way it's evolving. And it's probably a good thing, because the more of one thing that you do, you tend to become more skilled at that. And if you're not doing enough of the other disciplines, your skills kind of wane a bit, you know.
And so what's your main interest?
So my main interest is spinal surgery. I still do a lot of brain tumours because that was my training, and also by necessity when we go to Papua New Guinea, which we'll talk about later, quite often, and we see a lot of brain tumours. So I still do a lot of that, but my day-to-day work would be mostly spinal surgery. So neck, and lumbar spine sort of surgical issues.
Okay. And so I started off my training and I worked for the first 10 or 12 years of my career in the UK and Northern Ireland. And I have to say, there's definitely a bit of a difference in the amount of spinal and neck surgeries that I see here in comparison. And one of the things that people often talk about colloquially is a slip disc. They've got a slip disc in their back or a slip disc in their neck. What do people mean by that?
I guess the colloquial term slip discs means that they usually implies that they've got pain from a ruptured disc. It's a bit of a sort of loosely used term, so we don't really use it medically, so to speak. And we try and be a little bit more specific, and we'll either say you've got a disc bulge, or you've got a disc rupture, or you've got a sequestrated fragment where there's actually a discrete fragment. So that's just kind of the colloquial term slip disc, and we wouldn't really use it. But I mean, basically what it implies is that you've got a disc issue, and that's often associated with nerve pain. And that often dictates how it's treated, depending on whether you've got nerve pain or whether it's just spinal pain.
And how do you know if you've got a sore neck or a sore back when you need to go and have a scan or when you need to go and see a surgeon, for example?
So normally, if it's very severe and it's sort of unremitting and not settling with basic analgesics, that's kind of, you start thinking this is more than normal. The other thing is if it's associated with severe nerve pain, then generally we would say it's time to think about seeing a specialist if it's associated with severe nerve pain. But the reality is a lot of these conditions are self-resolving. So, for example, if you saw patients that had severe nerve pain, but they had no motor or sensory deficits and they were neurologically intact, obviously, one could wait a while before you send them off to see a neurosurgeon, because the vast majority of them don't end up needing any surgery. And most of these conditions are self-resolving. The natural history is that they tend to self-resolve. But generally, if it's persisting, not being controlled by normal analgesics, or sinister in terms of it's being associated with things like foot drop, sensory deficits where they have severe numbness, and of course the big concern with a lot of our patients is bladder and bowel dysfunction. And all those kind of red flags, then we'd obviously encourage you to rather refer them.
So can we just explain that a little bit further to our listeners? Whenever you say, so someone's got a really painful back and they've got nerve pain running down their leg, and what might be going wrong with their bladder or bowel? What might they experience? And that would be worrying.
So the majority of patients that have nerve pain, I guess, wouldn't have any bladder or bowel dysfunction. And that's reassuring. But occasionally, if you have a very large disc that's pushing on all the nerves, and we call that the cauda equina, which is like the central nerves, and it sort of resembles a horse's tail, because it's a whole array of nerves going through the central canal. And if they get compressed, that can cause bladder dysfunction. And it's usually the inability to void spontaneously, but occasionally it could present with just spontaneous voiding where you can't control your bladder. And that's a concerning sign, because often if that's left untreated for a long time, that can become permanent in terms of damage. But then we also see a lot of patients when they have such severe pain and they're in so much spasm that tends to also impact on their bladder function. And a lot of patients, when they're in really bad pain, tend to have issues with continence, and it's not necessarily from nerve compression. And that's where the importance of an MRI would come in to differentiate whether it's just severe muscle spasm or whether it's associated with cauda equina compression.
One of the things that I see patients potentially do wrong, although I understand why they do it, is they take to bed because their back is hurting so much. And people say, I haven't been able to get out of bed for 3 days. Do you agree that that's definitely not a very good thing to do? What would you recommend people do when they have a really painful back?
Yeah, definitely. I definitely agree that the old way of treating it, going to bed for a few days, is not ideal. You're better off with like activity modification, where you're appropriate in what you're doing, but you try and stay mobile, and that you tend to then try and break that cycle of muscle spasm. So we would always say to patients, be sensible, avoid any heavy or physical stuff, but try and stay up and about and try and stay mobile, because I think sort of being in bed and being immobilized leads to a whole array of different issues that don't really help the condition.
Do you think there are any occupations that seem to struggle more with back or neck issues?
Definitely. Only yesterday I was seeing a hairdresser for her neck, dental assistants, dentists. In terms of environmental factors such as leaning forward and bending and twisting your neck. So we do see more of those, and then we see a lot of patients that are, you can imagine, spending long days working on vibrating machinery, like diggers and that sort of thing. I think that.
So tell me more about that. Tell me what's going on there.
Yeah. So if you're sitting in some of the, especially the older machinery where they didn't have sort of hydraulic seats and various, more modern equipment, and you get a lot of that heavy sort of axial loading, repetitive axial loading, where you're bouncing on hard ground. That does tend to, we see quite a few of those patients with spinal issues, and I think it's a cumulative damage over many years.
Right. Okay.
And so we would see a fair few of people, say, who work on diggers and that, and then other things, also just labourers, so hard labour such as using a shovel, and where you have that acceleration, deceleration forced. There's a thing that they described called a clay shoveler's fracture, where you get an avulsion of the spinous process in the neck, and that's just gives you an idea of the forces if you're using a shovel into hard ground. So we do see more of those, but there's so many other factors, that play a bigger role, like genetics, and other factors. So it's not just the type of work.
Right, okay. I definitely see, or used to see, a lot of nurses as well who would be also moving patients around beds and things, would end up hurting themselves. So tell me a little bit about the other factors that contribute to back injury.
So I think no doubt genetic components is very important. And some people, a fair proportion of people would be more predisposed to premature disc degeneration. And there are various entities, particularly something called Sherman's disease, which is quite common. And we see it in adolescence, where you get aberrations of the disc, and the discs look a bit corrugated. And the theory is that if you have that Sherman's disease, which is an autoimmune phenomenon, you tend to be predisposed to having disc degeneration a little bit earlier in life. Okay, so that plays an important role. Just the genetic factors, we do see some families where they seem to have more premature disc degeneration. And then other environmental factors like smoking. Smoking is quite an important factor for disc degeneration.
Wow. So what's the mechanism of that?
I think it's some sort of denaturation of proteins over time. Dehydration plus some protein denaturation, but and also devascularization of the end plates, which is the margin of the disc, and the discs and the vertebral bodies. And we also know, like, smokers tend to heal a lot slower. So smoking, diabetes, anything that gives you a vasculopathy is likely also to affect your disc integrity.
Right. Okay.
Yeah.
What about weight?
Weight's interesting in that it's the mechanical loading that has a significant impact over time. So think about a person who's, say, carrying an extra 30 kilos and the impact that's going to have on their load-bearing joints like the knees. And what tends to happen with the lumbar spine is it tends to cause more, slightly more sort of loading of the discs and more hypertrophy, enlargements of the facet joints. And then one of the biggest factors is, as we age, our posture changes. And spinal health is all about biomechanics. So we have these fascinating talks, mostly originally by the French, where they explain to us how important it is that when we're standing and we're ambulating and we're upright, our center of gravity, which is called our plumb line, should be over our pelvis. And think about it, as we age, they say life is a kyphosing event. So as you age, you start leaning forward. And it's like a crane. As a crane leans forward, there's more torque on the base. And that's why we see patients where they have bad backs and they're leaning into trolleys. A lot of our patients say, Doc, after 10 minutes of shopping, I have to sit or I have to lean on a trolley. And if they don't have a trolley, they're in trouble. That's because their center of gravity, it's called their sagittal balance, is out and they weigh forward. So there's a lot of torque through the back muscles. So it's really interesting. It's all about biomechanics.
And so do you want people to resist doing that? Is that making it worse, leaning on the trolley, or?
No, it's more a question of once that's happened, it's already established, and it's a question of understanding that. And it's very important in those patients that need surgery that we pay attention to trying to reconstruct their balance, to bring their shoulders over their pelvis. And what we've noticed, there was the old dictum that if you fused one level, it led to more problems, like a domino effect. But what research has shown us is if you fuse them in an aberrant position with their backs leaning forward by using sort of straight rods and the old-fashioned technique, of course they're going to deteriorate because you're putting them in a very unphysiological position. But if you keep them in a nice lordosis whereby their shoulders are over their pelvis, it's amazing how long how many more years the rest of their spine actually lasts. So it's all about being in balance. And unfortunately, by the time you've got to the stage where you're leaning forward on something, the horse is sort of bolted,
And what about, obviously, once women go through the menopause, we've got this issue to deal with, which is that great increased risk of osteoporosis. How does that impact our back?
So osteoporosis is a massive factor, and it's a massive factor in Western developed countries. And it plays a huge role in terms of causing pain and also worsening posture. And I think one of the biggest issues we see is a combination of inactivity, chronic inactivity because of pain, plus painkillers, particularly opioids, plus not doing enough sort of resistance or weight-bearing type exercises. And I reckon those three factors lead to lots of premature osteopenia or osteoporosis. So if you've been on opioids, you're not active because of pain and you're not loading your joints, tends to lead to that. And that's difficult because it's very difficult to help those patients once they're very osteoporotic. Obviously the agents that can slightly reverse it, but I would encourage elderly patients to try and be as active as possible. And I've noticed that my patients that are, if they say, Doc, I'm still busy in the garden and still doing stuff all the time, lifting stuff, working, their bones are hard. And those that have kind of had a very sedentary life, it reflects in their bone mass.
Yeah, absolutely. The other issue that we're definitely seeing a bit more in general practice is people presenting with sore necks at a younger age. And I have to wonder whether these devices that we hold in our hands all the time and that everyone's looking at are impacting our necks. And are you seeing that, or do you think that's a phenomenon that's a real concern or not really?
No, it's definitely a real concern. I mean, it's quite well described where they're seeing a lot more young adults and adolescents with neck pain, and it seems that the environmental issues are becoming more and more, either working on computers or, as you say, mobile phones, tablets, all that sort of stuff. But I think it's that, but those are also generally the folk that maybe are not as active. Yeah. So it's a combination of, if you're on your phone all day and into the early hours of the night, you're probably not exercising as well. So it's a combination. I
have a physio who suggested to me that if someone's going to be on their phone, and I think the reality is that teens and whatever are going to be on their phone often for hours, is it a good idea for them to lie on their tummy and look at their phone so that they're in a slightly different position? Or do you have any recommendations? Because I think we're going to struggle to get those phones out of people's hands. Yeah. And I put my own hands up to being on my phone a bit. So what's the best thing that we can do to try and preserve our necks and keep that correct position?
I think making, adolescents and even younger folk and any people that spend a lot of time on their phone, make them more aware of the ergonomics. So they're not sitting basically with their heads hyperflex for a long period. So
hyperflex, just so our listeners, what does that mean to be hyperflex?
Kind of with your, chin to chest posture, with your chin down on your chest.
Yeah.
it's interesting, like years ago when I was operating long hours and I had a slightly shorter assistant, I noticed I was looking down the microscope with my head flexed. I was getting a lot of neck pain, and the only thing that really helped that for me was I started paddling a bit and doing a bit more shoulder exercise. So I think just being aware of it, being vigilant to the ergonomics of what you're doing, and then aware of what, the options are. And if your neck muscles are cold and you haven't been using them and you haven't been exercising, plus that posture, it's sort of a bad combination, because you get a bit of atrophy and then, of course, the protracted chin on chest posture. So yes, I think anything that that encourages them to be more neutral or more mobile with their postures better.
What are your thoughts on people having their backs cracked or their bones manipulated? Is that something that concerns you, or is it something that you are comfortable for people to go off and see various practitioners for?
I think, that's a really good question. Firstly, the reality is most people that have back pain probably get more relief from the chiropractor than when they go to see their neurosurgeon, and they don't really need to see a neurosurgeon. So the practicality of a very common condition is that the chiropractors are helping a lot of people every day. I think there's a few key issues. The one issue is we need to know when you shouldn't be going to a chiropractor, and we also need to know certain red flags. And if you're aware of those, and if you have a very good chiropractor who's aware of those red flags, then I have no issue with it. So for example, these days we work closely with the chiropractors, and a lot of them would contact me and they'd say, Mark, I'm concerned this patient's got a very tight cervical cord on the MRI. I'm not going to manipulate them because of the red flag. So it boils down to knowing which patients it's dangerous to manipulate. And if they've been adequately worked up with imaging and that, then there's no issue. But if everyone who comes off the street gets manipulated without any imaging and without a proper neurological examination, that's when you run into trouble.
Okay.
So what I mean by that is, for example, if you've got a tight spinal cord, it becomes tighter in hyperextension. So think of that crash test dummy posturing.
Okay, so hyperextension, just for anyone just listening, is whenever you're tilting your head right back as far as it goes.
And now imagine forcing it back and amplifying that. So what that does is it corrugates all your ligaments. If we do an MRI in extension and flexion, we notice how the spinal canal narrows significantly. And we actually do those MRIs in some patients. We get them to flex and we get them to extend in the MRI. And it's incredible, the difference.
And so explain to us, what are you looking for and why?
Yeah. So say you've got a narrow spinal canal, and we shouldn't really be doing scans with people lying on their back because we're not lying recumbent all day. So it's like testing a car's shock absorber with a car on a hoist. You're not really seeing what's going on. So sometimes now we use functional MRIs, where it's like an open machine and the patients can actually move their neck and you can see what's happening to their spinal canal when they're moving it.
Right, okay.
Yeah, which makes more sense.
Okay.
So it's dynamic. It's not lying non-weight bearing.
And what kind of symptoms would someone with a tight cervical spinal canal be complaining of?
Yeah, so broadly that either be complaining of radiculopathy, which is nerve pain down the arm, or sometimes they're complaining, if it's spinal cord compression, it would be more widespread symptoms like headaches, pins and needles in both arms, weakness, electric shock-like sensations, gait changes, and then particularly issues such as inability to, when they're walking, their proprioception, their sense in space is altered. So we see that more with spinal cord compression.
Okay. And why would they be getting that?
I guess the spinal cord is kind of like the main branch of the tree or the main trunk. It's a gateway for all the signals to the legs. Whereas if it's just going down the nerve, it'll just affect that extremity. So I always think of it like a fir tree. If it's a branch going down to the arm, it's only going to affect the arm. But if it's the main trunk, like the spinal cord, it can affect everything.
And would that be like a bony or disc issue compressing?
Yeah, exactly. So it's usually either an osteophyte, a bony issue, or a soft disc. We tend to see like a soft disc rupture more often in young people because their discs are more elastic and they have more sort of malleability. And in older people, we tend to see more osteophytes, which is spurs. And interestingly enough, there seems to be a predominance in people of Japanese or Indonesian descent where they get more calcification of the back of the discs. And we see that a lot more in places like Japan, Indonesia, and that.
And so if someone has got like little bony spurs, which are like little bony spears, really,
Yep.
Do you have to go in and remove those, or?
No, I mean, the interesting thing about spinal cases is we always say treat the patient, not the scan. And if you look at people in their 60s, 70s, and 80s, the vast majority of patients would have spurs, but very few of them have symptoms.
Yes.
And so we've got to remind ourselves that developing osteophytes is part and parcel of aging, and we only need to really operate on those patients if they've got severe pain, not settling or associated with things like weakness. But the majority of the cases will settle, and it's identifying those that really need surgery or not settling.
I agree with what you said there. I do find that sometimes patients have had an MRI scan for whatever reason, and they maybe get told, oh, there's osteoarthritis or there's this or that. And, you know, years can have passed, but patients can still be walking around with basically that backpack of a diagnosis, kind of limiting their choices and limiting what they're doing because they seem to be sort of living their life through a radiology report on a scan.
Exactly.
And is that something that you would see and sort of be wanting to encourage people not to live by their scan per se?
Definitely. Especially the classic is people being told they've got bulging discs, you know, which is really a physiological condition where your discs bulge. I always say to patients, it's sort of like driving your car for 40,000 Ks. You're going to have a bit of wear and tear on the tires, but that doesn't mean it's not physiological.
So just explain what you mean by physiological.
So what I mean by that is it's normal to have bulging discs beyond a certain age. And as long as they're not causing nerve pain or nerve compression or encroaching on any structures. So a lot of patients would say, gosh, doc, I'm worried. I've been told I've got bulging discs, and they can see a slight bulge. But the better way to look at it is if you looked at, say, 80-90% of the population in their 40s and that, it would be normal to have some bulge in your disc or some sort of, we call it laxity of the back of the disc or the annulus.
Okay.
And of course you only really have to focus on treatment if it's causing problems. So you're absolutely right. We have to be careful that we don't have these radiological diagnoses that limit what we do, and we need to interpret that information correctly, appropriately.
Marc, in terms of looking after our backs, what are the things that you wish that people knew and perhaps did a little differently?
I think the most important thing, in my opinion, is lifestyle. And it does worry me a little bit about the next generation sort of being on electronics and that. I really think that, to have a healthy back, you have to have healthy muscle around your back. And I think that's one of the biggest factors. And I've seen it in my patients. If they've lost a lot of muscles, and they have severe sort of disuse atrophy, then you get more load through you get more load through the skeletal system. And I've also seen the corollary of that, where you have someone with a terrible looking back, say from rugby or for scrumming for 20 years, but they have such good muscles around their spine that they seem to be coping. So for me, that's the biggest thing. Activity, having an active lifestyle. And I think that'll lead to sort of backs that may not look the best radiologically, but functioning quite well. And these days now, we don't just look at the discs, we also look at the muscles. And we look at the erector spinae muscle, which is the muscles at the back of the spine. And you can see there's a thing called fatty streaking. And that's where a lot of your muscle fibers atrophy and they get replaced with adipose tissue. And I always liken that to imagine having like your knee joint with no levers around it or no muscles around it. Has a massive impact on the load through the joint. So I think that's the biggest factor.
And is there any exercise, type of exercise or form of exercise that you think is great for backs? And is there any exercise that you think is more risky for back?
I think any exercise where you are incorporating some sort of load bearing sensibly is good. So, if you're doing a light gym program, any exercise that incorporates stretching Gentle traction tends to be very good. So things like Pilates, gentle yoga, anything using your core muscles tends to be good. Anything where you have repetitive, jarring mechanical forces through it, probably not so good. That's only one factor, and I would say the vast majority of exercise is good for your back. And what you do, obviously, you have to tailor it to your spine, your type of issue that you may have. But by and large, most exercise is good. I mean, the exercise that we sort of tend to pull back on would be, I've seen a lot of problems with very heavy like weightlifting. I have to be honest, I think doing certain exercises like deadlifts, squats, and various things where you're loading your spine and you're using your spine as a fulcrum, I'm a bit nervous of that. I know the purists say, oh, it's all about technique, but I think for the average person who goes into a gym and hasn't done a lot of gym, and the next thing they're doing Romanian deadlifts and they're being told their technique's okay so they can keep going, it's a fertile ground for back surgery.
Absolutely. You've got a first-hand knowledge of those people.
You'll be very careful, yeah.
Yeah, okay. I think it's probably my last back question is, why would you do spinal fusion surgery? What's the thinking behind that, and what does that actually mean?
So spinal fusion surgery essentially means that you are fusing two vertebrae. In the sort of classic teaching, it was really only to be done if you had severe nerve compression. So the classic indication would be two vertebrae that are slipped, and that's called a spondylolisthesis from the Latin word, or two vertebrae that have collapsed into one another, and of course they're pinching the little nerve as it exits the foramen. If you can decompress a nerve, and when the patient's standing, it stays nice and decompressed, that's fine. They don't need a fusion. But if you decompress a nerve, and as soon as the patient stands, their back becomes unstable, and those two vertebrae shift, and they start pinching the nerve, those patients often need a fusion. So there's a concept of something called spinal stability. So imagine when you're standing and your back's like a spring, and as you compress it, those little rings of the spring move around and they pinch the nerves going through the middle. And so that those patients would tend to need a fusion. And nowadays, though, things have changed a little bit where you can occasionally offer fusions to patients where they don't have severe nerve pain, and you can sometimes offer it to them for things like back pain. And there's an array of non-fusion technology that's also come out. So things like disc replacements, motion preserving devices, and so they can also help. So fusions still play a big role. You have to be cautious who you fuse, because as you know, it creates a domino effect and you can't unfuse it. So it's a card that you've then played. But we tend to use it for patients where they have unstable spines.
And when would you put in a disc replacement?
So a disc replacement tends to be very effective for younger patients when they have a ruptured disc and they have discogenic pain. In other words, pain emanating from the disc. And the one aspect is you need to still have good facet joints. So if you remember your basic anatomy, each segment or each level consists of a disc and two facet joints on either side. And it's kind of like having a car tire with a shock absorber. If the tire is so worn out, the disc is so worn out that the shocks are gone, you can't then go and replace it with a mobile disc because the facet joints will be damaged. So it's disc replacement is really good for young patients where they have terrible disc pain, hasn't settled with the passage of time, and their facet joints are still preserved. And you want to give them a device that preserves motion, so you're not fusing them.
So Marc, I'd like now to shift our focus away from backs and necks and talk about the brain. I think lots of people, it's a big fear of having a brain tumour. If people develop headaches and they haven't really been a headachy person, or even if they have, often it's at the back of people's mind that they're worried about a brain tumour. Can you tell us what are the symptoms that you would be concerned about that might make you think this person needs to have a brain scan?
I guess the commonest presentation still would be intractable headaches, and it's usually headaches that are pretty severe, out of the ordinary, not responsive to basic painkillers like the ordinary headaches. They tend to be worse when patients are lying down because of the pressure effect, but not always. And they tend to be associated with other things like issues with your vision, sometimes vomiting if there's raised pressure, other times associated with more subtle things like personality changes. A lot of patients, particularly if it's frontal or temporal lobe tumors, they can become slightly disinhibited. And then, of course, any headaches associated with weakness, change in movement of one of your limbs, all of that often suggests it's a bit sinister. But we have to see it, keep it in perspective. Headaches are a very common issue. And obviously, thankfully, the vast minority of patients with headaches don't have anything sinister. But I think the one thing I would say is if someone's got a persistent headache, it does worry me when they go through for a very long time with bad headaches complaining, particularly children that don't have an MRI. I'd be inclined to not over-treat them, but have a low threshold to do an MRI scan if someone's continuing to complain.
Yeah. And do you think that a headache from a brain tumour is a headache that comes and goes a bit, or is it just constant?
It tends to be constant, but I have to say they don't follow all the rules of the textbooks because of where they are, the size, the rapidity of which they're evolving or growing. So I think those guidelines that we were taught, what I've learned is they're really just a rough guidelines. And if your gut feeling as a GP or a doctor tells you there's something not right, or more importantly, even as a parent. The other thing I've learned is that, they always tell you don't ignore the parents, and it's kind of, this is one situation where it's true. If the moms come in and they say, look, this is not normal, my daughter's had this persistent headache, I would be inclined to generally do a scan.
Yeah.
Especially if it's been persistent for a long period of time.
And I've had some patients mention to me that they feel like they're hearing of more people with brain tumours. Yeah. Is it something that's getting more frequent, or is it just that we're able to investigate them better, or do we think that they're becoming a more common occurrence?
That's a really good question, and from the literature it appears that they are becoming more common. I think some of that is also that they're being picked up quicker and they're being picked up earlier and we're more aware of it. But with that whole investigation thing aside, I think they're also becoming more common. And I guess,
do we know why?
No, I knew you were going to ask that question. No, not really, although we think it may be some perhaps unidentified environmental factors may play a role. We know there's some genetic factors, but interesting one that often comes up is electromagnetic radiation from phones. And there were a lot of kind of inconclusive studies, but to me, the absence of a clear association doesn't mean it's not associated, So we've got to be very careful. I would always encourage people not to use their phones for hours right up against their temporal lobe. And, even my kids, I tell them just keep your phones on speakerphone if you're going to have a long conversation, because I can't help thinking that maybe down the track we'll look back and we'll ask questions and say, was all this EMR safe? And
in terms of treatment, I actually have had a medical colleague whose child had a brain tumor and sadly passed away, but I know that they traveled overseas and, there was lots of different treatments sort of being explored in terms of brain tumors. Is it, for want of a better word, is it an exciting and innovative time in terms of where we're going? Is it more hopeful than it used to be, or?
It's definitely very exciting in terms of where things are going. And yet, if you've drawn a short straw and you get a very bad aggressive tumor, we are stuck in the same frustrating prognosis that we were stuck in many years ago. So people who do lots of brain tumors, like Charlie Tier and that, if you hear them talking about how little things have changed in terms of how we can alter longevity in an aggressive grade 4 glioblastoma. For me, that is like one of the most feared diagnoses because there's just so little that we can do. And it's because those tumors are infiltrative and they're not growing outside the brain, they're growing within the brain substance. And they tend to be very aggressively evolving. Now, there is a sort of biological field that's not within my expertise, but I think that's exciting, whereby you get various vaccines and things that can potentially try and fight these genetic aberrations. I think that's where the future lies. It's going to be in sort of genetically targeted therapies rather than, things like radiotherapy and the traditional things, which is if you think about it, radiating the brain it's a pretty crude form of trying to treat a disease process.
Yeah, absolutely. It is interesting that they're coming at these things from a sort of an immune basis. So it does make you wonder what was the original trigger if they're responding to some types of complex immunotherapy, really.
Exactly. I mean, the other thing that's encouraging is if you look at the majority of brain tumors, if they're picked up early, and if their histology or their pathology is favorable, they can do really well. And other side of that is when you travel to third world countries, and that's the most tragic thing that I've seen is when we go to Papua New Guinea, the most common presenting symptom in Papua New Guinea of brain tumor is blindness because they've had it for so long. And that's the other side. If it's neglected and they're not imaged and you pick them up at the late stage, it's frustrating because none of those patients should have developed blindness. That's from raised pressure over years often.
Yes, absolutely.
Yeah.
So tell us a little bit about your charity work in Papua New Guinea.
The Kokoda track, and I did that with my dad, my brother, and at the time I was working with Charlie Teo. Really loved the country because it was just so wild, and it was like this unexplored frontier. And it reminded me a little bit of parts of Africa that I traveled through as a student. And then I went back a few years later and we did a fishing trip where we went to West Papua. Basically, it's just, you can only access it by small plane. There's no roads. And I just couldn't believe how undeveloped it was. There were essentially people still living in these sort of waterways, completely almost undiscovered, really. And then a few years after that, I decided to go back and look at doing some work there. One of my friends asked me to go because they'd bought a microscope for the hospital. So I helped them launch that. And that was about 5 years ago. And subsequent to that, we've been doing sort of every 6 monthly type missions where we go and we operate, and we also help the local trainees, and we're doing a lot of teaching. And one of them have actually come over for a year. So they're working with us for a year.
Nice.
And it's been a absolutely wonderful project. I really love going there, and we've made a big difference so far in that we've done a lot of training, teaching, and taken over a lot of equipment. So it's exciting to see neurosurgery evolving. It's a massive country, and there were no neurosurgeons there, so you can imagine it was a huge void.
Wow! And so, if any of our listeners would like to help support your charity work there, is there anything that they can do or anything you need help with?
Absolutely. So if anyone's interested in helping charities such as this, we have a website called PNG Angels, and you can go online and you can see the type of work that's been done and contribute that way. The nice thing about the charities is completely run by volunteers. So all the doctors, nursing staff, they're all from the local team, and they sort of just give up their time for free. So any money donated literally goes to the logistics of the charity, such as equipment, consumables. One thing we learned early on, if you go there and you take nothing, you can't do any surgery.
Right.
So we try and take like a ton of surgical stuff. So all the stuff to stop bleeding, suture material, all that equipment. And now we've built like a stockpile of equipment. So the local surgeons are using it, and every time we go, we try and take more.
And what about in terms of like hygiene and technology and the operating theatres? Like, what type of standard are they?
Yeah, it's pretty mind blowing.
Pretty basic?
It's pretty basic. I mean, the first trip we were there, we noticed a lot of the theatre staff would be using like thongs in theatre barefoot, It's very, very basic. Like, you'd be operating and you look up sometimes and there's an insect or some flies. So it's completely different. But what also amazed me is the amazing work they could do in that environment. And the doctors there are amazing. They're so used to working in a difficult environment, and they make do with what they've got. And they don't just sort of sit back and complain. They actually get on with it, and it's amazing what they can do.
Yeah, I'm sure you've met some pretty great characters over there.
Definitely, and fantastic, really fantastic people. Just very, very patient, very grateful. when we go and do those trips, they put out like a bush telegraph to say the neurosurgical team's coming. So these poor people will come from different provinces, and they often travel for days because there's just no road network. So they've got to fly or walk or...
So for anyone listening, Papua New Guinea is an island nation north of Australia. I have no idea of the population. Do you know what the population is?
So they have, I think their population, it's pretty big. I think I don't know the exact amount, but it's significantly bigger than Australia.
Population-wise?
Yeah, yeah, it's a big population, and they've got 100 different languages, more than 100 different. So it's actually the most biodiverse place on earth in terms of like different dialects. So if you go to West Papua or you go to New Britain, which is on the north coast, completely different to the other areas, different dialect, and almost a blend of like Polynesian people. But it's a fascinating country, and anyone who's interested, it's quite sad. It's only 4 kilometers from our shore, and it's kind of like it's a neglected world.
Yeah, amazing. All right, well, thank you. That's so interesting, and hopefully anyone listening who can help will help. And my final questions to you are about science, technology, artificial intelligence. Do you think that there's going to be, or is there already, moves to use robots and things in neurosurgery? And what do you think the future is going to look like for a neurosurgeon?
Definitely. It's a very exciting field in terms of new innovations. Not only that, but also things like some of the new stem cell technology. I'll just give you an example. A lot of people are already using robotics. I haven't veered much into robotics. I'm a bit cautious about robotics. I always say to people, the robot's kind of only as safe as the person driving it. And if you have a bad outcome, it still falls on the surgeon's shoulders, and can certainly be significant issues. And we have seen significant issues, safety issues associated with robotic surgery. So I think maybe the next generation of surgeons, no doubt they're going to embrace it and use it. At the moment, we do a lot of intraoperative navigation, so we use that every day. And we use a machine called the Body Tom, which is an intraoperative CT scan. And in fact, at North Gosford, we're pretty proud to say we've got the first kind of new generation one in the world. We were the first one to get in the world, where you have a diagnostic quality CT, so like a really good quality CT, but it's mobile, it's on wheels. So we use that every day when we're operating, and it's a navigation system. It shows us, before we even start the incision, which direction we're heading in, and it shows us exactly where all the structures are. So it gives us enhanced safety, and that's played a massive, massive role. And then the other thing that's playing a huge role, and I'm really excited by it, because we did the first 3D printed implant in Australia in the spine many years ago, almost 10 years ago now, in 2015. And so now we're doing a lot of patient-specific implants, whereby the engineers will take your scan and they will make an implant that's specifically to fit your vertebra.
Wow.
Yeah, and that can be done literally in 24 hours. So a lot of exciting technology, but I think we have to make sure that technology remains human-driven, and we still have to be able to fall back on old-fashioned ways, not rely too much on the technology.
Yeah, have the skills, so you're
absolutely
cautiously excited.
Exactly.
You've mentioned Charlie Teo, and I know that you did some training with him. Yep. And obviously within Australia and probably worldwide, he's got, yep, definitely a big reputation. Yep. Can you share a little bit of your learnings from your experience working with Charlie?
So I did a fellowship I met Charlie when I was in Cape Town years ago when I was a registrar. And of course, as you know, he's quite a colourful character. He's very unique. And just remember, first meeting, we had a really good time in Cape Town, and I said to him at the time I'd love to come over to Australia. And then years later, I came over, in fact, and did a fellowship with him. And that was a great experience. I learned a lot of surgical skills from him in terms of a technician, and in terms of his surgical skills. I certainly learned a lot from him, and I'm still very grateful to him from passing on those skills, some of those skills. He was fantastic in terms of a technician.
But has obviously courted a bit of controversy.
Absolutely. I think fairly or unfairly so, there's been a lot of controversy around him. I would say that, in the surgical world, I think there should be space for all types of people. And I think it's sad that Australia has lost him or lost his skills. But I see both sides of the story. And I think being a surgeon is also not just about being a technician. You also have to make decisions. But I think it is sad. I think it's a loss for Australia in terms of his technical capacity.
Yeah, and I think whenever there's, things like children with brain tumours, it brings up so much emotion. And I know that, as a mum of 4, and I know you've got 5 children, there's definitely people who would feel like they would do just about anything to save their child.
Definitely. I think overall medicine's done better if it's done collaboratively, and if surgeons talk to each other, cross-refer, have open, honest discussions about what they can and can't do. And I think it's better outcome for the patients.
Yeah, absolutely. Alrighty, well, I just have one final question, which is if you could tell 20-something Marc one piece of advice, given everything you've learned and everything you've lived, what would you tell yourself or your younger self?
Gosh, that's I think, life's, I guess as a surgeon, we see it every day. Life's a gift, it teaches you there's such a fine line between death and living. Don't take any day for granted. And then I think just as a surgeon, looking back on maybe, 20 years of surgery, I realized that I'd say to my children every day, life's about a balance, and just when you think you know everything, you realize you know nothing. And I think, surgery is very humbling because things can go wrong no matter how experienced you are. And the people that I probably respect the most as surgeons are some of my mentors that were very humble. And I look back at them and I'm just as I get more experience and as a better surgeon, I'm just more amazed how good and how humble they were, especially some of my mentors in South Africa. So that's what I'd like to pass on to younger surgeons and that's what I love about going to Papua New Guinea is just when you think you know everything, you realize you're just scratching the surface.
Amazing. Marc, thank you so much for being so generous with your knowledge, and I'm sure the listeners are going to love listening to this.
Thank you, Shauna.
I think you'll agree we've had some incredible guests on the podcast already, and today's was no exception. I think there is so many nuggets of information I'd love to get out there. So if you know someone who would benefit from the podcast, please share it. That way more people can learn all about themselves. Remember, this podcast is all about you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.